Hello everyone and welcome to today's ComDARN webinar. My name's Angela Argent and I'm your moderator for today. ComDARN and partners are delighted to welcome our presenter for today, Associate Professor Frances Kay-Lamkin, who will be discussing effective models of care for comorbid mental illness and illicit substance use and evidence check. I'd like to thank our partners today, the Mental Health Coordinating Council, NADA, the Mental Health Commission of New South Wales, UNSW, NDARC and CREMS, and welcome you all here today. Before we kick off today, I'd like to acknowledge the traditional owners of the land on which we're gathered here in Sydney CBD. We're meeting on the land of the Gadigal people of the Eora Nation, and I pay my respects to their elders both past and present. I'd also like to extend a special welcome to any Aboriginal people joining us today. At ComDARN, we value the lived experience and strengths of people recovering from mental distress and the harms caused by alcohol and other drugs, dispossession or trauma. I'd also like to just put in a bit of a plug for my project. I'd love for you to visit the ComDARN website. I'd love for you to join ComDARN. It's free and very useful, and we'll keep you updated with all of the events that we have, like today's webinar. And I'd love you also to think about joining the ComDARN Research Mentoring Project. Again, it's a free project and it enables you to begin to kick off your research project for the first time with the support of postdoctoral students from UNSW and other universities who are our partners. And it's a great project for letting you just get started in your research. I'd now like to introduce Frances. We're really lucky to have Frances here today. Frances leads an innovative research program internationally that's recognised for its impact, research quality, and commitment to translating research into better practices. Her work focuses on areas of critical need about increasing the evidence base and clinical translation for treatments for co-occurring mental and physical disorders. She's an NHMRC Career Development Fellow and a Director of Translation at the NHMRC Centre for Research Excellence in Mental Health and Substance Use, where she leads an international team of researchers, clinicians, and industry partners in innovative development and translation of evidence-based treatments. Frances's vision is to bring high-quality treatment to the point of care for people experiencing mental and physical disorders, to ensure that the right person receives the right intervention at the right time. Her most recent successes include a prestigious NHMRC Research Fellowship and a TRIP Translating Research into Practice Fellowship. She's also currently serves as a Secretary and Public Officer for the Society for Mental Health Research, the ABC Mental As program that you've probably all seen, and its efforts to engage the Australian community about mental health and wellbeing. There's over 5.5 million TV viewers last year attracted to this program, and this program really supports researchers to support consumers. Today we're going to kick off our discussion with I've put up a bunch of questions that come from the ComDARN project reference group. And these are questions about a lot of things, about translating research evidence into better practices. We'll go through each of the questions individually later. Some of them are about just supporting the needs of individual people, and also how we think about models of care that are not sort of expert models in relation to the range of things that Frances will be talking about today. But without further ado, I'm very, very excited to introduce Frances to you. And I hope you enjoy today's webinar very much and learn heaps about translating research into better practices. Thank you.
Thank you very much, Angela, and to everybody attending today. It really is a privilege to be able to come and step out of my research tower, if you like, and talk with everyone today on something that I'm quite passionate about, and I hope to communicate that passion here today. So you've heard a very, very long and lovely introduction, thank you, about me and my academic background. And so I just wanted to take a few minutes to gauge who we've got playing into the webinar today. So if you just take a moment to complete the poll that hopefully is coming up on your screen, just to indicate what your professional background or interest is in models of treatment for comorbid mental health and substance use problems. So a lot of, about a third mental health clinicians, we have around 20% drug and alcohol clinicians, Around a quarter of our attendees are community workers. We've got some researchers. I'm pleased to see consumers as well, and also some teachers and educators. So quite a good range of backgrounds and hopefully interests. And I think that's reflected in the questions that we've already put up today, or Angela's already put up today. So I hope that some of my presentation will answer some of those questions, and for those that aren't answered, I'm very happy to talk about that at the end. Okay, so I hope I guess we're all in agreement that, by our attendance here today, that comorbid mental health and substance use disorders are really one of health's most significant challenges. And one of the reasons for this particular challenge is that the prevention and the treatment evidence base has really been limited until recent times by traditional single disorder models, so focusing on treatments that either focus on the mental health part of a person's experience or the substance use disorder, and also treatment silos. So traditionally we still, we have seen in the past that drug and alcohol services and mental health services can operate somewhat independently of each other. And that's something at the Centre for Research Excellence in Mental Health and Substance Use, CREMS, that we're really trying to overcome through increasing the evidence base for a range of treatment models for comorbid disorders, and also for individual treatment strategies and approaches to better help people address their own challenges and experiences with comorbidity. And so to that end, we were commissioned by New South Wales Health, the Mental Health and Drug and Alcohol Office, via the Sachs Institute, to conduct an evidence check of all the available existing evidence for models of care, evidence-based models for care, and evidence-based treatment approaches for comorbid mental illness and illicit substance use. So we tried to summarise in a very, very short amount of time. We only had a 3-month turnaround on this particular piece of activity, to really try to get a good handle on not only what the evidence was saying in journal publications and so forth, but what evidence we could see for models of good care for comorbidity that existed in New South Wales particularly, and Australia more generally. And certainly went internationally as well. And what we found largely was what we'd also been able to see for a number of years in our own treatment research in comorbidity, that the treatment research and the published research using comorbid populations really was the exception rather than the norm, despite comorbidity in practice being the norm rather than the exception. And I'll just, we're giving a few plugs. I'll give a plug for the actual report that we were able to produce via the Sachs Institute for New South Wales Health on the stuff that I'll talk about today. You can see the web address there and so forth if you want to access the full report. So how does the literature tell us that comorbidity is traditionally managed, and where is the evidence base starting when we start to consider co-occurring mental health and drug and alcohol use problems? So certainly when a person is seeking treatment, they're likely to experience one of these particular treatment models. So we have a sequential treatment model where, for example, the mental health part of a person's experience is dealt with first, and then once that is resolved or managed or a bit more manageable, they then move on in sequence to manage or to focus on a drug and alcohol aspect of their presentation. And that can often be done by separate services, can be done by different clinicians, and usually does occur in that one after another sequence. We also found evidence both in the literature and in the clinical practice models that we had available to us of parallel treatment. So that is that both a person's mental health symptoms and their drug and alcohol use patterns were being dealt with at the same time, but this was often in parallel services by parallel clinicians, and for a lot of the time there may not have been too much integration or coherence between those two parallel forms of treatment. We then, over the last 10 years or so, and particularly with the research coming out of CREMS, have come to see more of these integrated treatment models appearing in the literature, and some examples of that in clinical practice. So by integrated treatment, what I mean here and what we mean here is a clinically integrated treatment where the one clinician really helps a person address both a mental health and a substance use concern within the same treatment program, often within the same treatment session. And one of the benefits we think of going with this type of treatment approach is that a person can understand and get a bit better of a handle on the relationship between their mental health symptoms and their drug and alcohol use, and also develop coherent strategies for addressing both as they occur independently of each other, but also how they are related. And again, more recently, we were seeing evidence emerge of stepped care treatment. I'm sure the clinicians amongst us all have been doing this for years and years and years, and researchers are a little slower to catch on to these types of things. But stepped care is a model whereby everybody who comes into a service or this particular treatment model receives the least intrusive, least intensive intervention first, and often this can be an assessment and maybe a very brief intervention. And then based on their response to that, the person's response to that first intervention, that first low-level intervention, subsequent interventions are arranged and provided to the person. So in the example of comorbidity, we saw in our review some examples of a person, of services offering an initial brief intervention that might be integrated in its initial approach, both in its assessment of both mental health and substance use, and also its initial goal setting and some motivational interviewing around both of those particular concerns for a person. And then after a further assessment, if people were still experiencing issues with mental health concerns or they became more pressing, then they would be offered a mental health focused treatment. If it was a drug and alcohol concern that was most pressing or still present for the person, then that was the nature of the treatment that followed. Or if both issues were still there, then perhaps an integrated treatment followed. So really the snapshot view of what we found when we took to the literature and also some of the clinical practice around the place in conducting this review. Also from the review, we were able to identify some examples of how individual services within New South Wales Health, more broadly within Australia and then somewhat some internationally as well, were actually trying to work through this issue of comorbidity. So we were able to identify some very specialty comorbidity services that were set up and kind of operated in between mental health and drug and alcohol services. So examples of this were the Triple Care Farm, which some of you may be familiar with, but also the CMHDARN model in Canada. So these were, again, independent services set up specifically to address comorbidity, comorbid mental health and substance use problems. We saw some really great examples of how drug and alcohol treatment and drug and alcohol services tried to integrate into mental health services. So some specific models that are in use in New South Wales at least are the Coexist New South Wales model and also MSUS, Mental Health Substance Use Service. And for the latter example, a drug and alcohol unit sits with drug and alcohol clinicians, sits within a mental health service. People are recruited or identified through an inpatient admission and then engaged and followed up in this integrated drug and alcohol service that sits within the mental health service once they are discharged from hospital. There were also some examples, mainly internationally, but a few in Victoria and also in New South Wales, where services had provided an evidence-based comorbidity framework within which they were making moves and trying to garner support to fit and assess services. So they were looking to have a look at what they were already providing in terms of being able to adequately and comprehensively address both a mental health and a substance use problem with a person, and then to identify some gaps and to develop a framework around which they could perhaps improve on their response. But as I'm sure everybody can imagine, to try to restructure an entire service, or in fact a couple of services, mental health and drug and alcohol services, within an evidence-based comorbidity framework can take a lot of intensive restructuring and financing. And so we also took note of those particular challenges, but also those particular examples of pockets of services where people were actually making some significant inroads into really trying to address mental health and substance use comorbidity in a comprehensive fashion. But really they were, people and services were largely coming up against some barriers in terms of the policies and the health systems that Australia in particular currently has in place. And so certainly this specialty segregation that we still continue to see somewhat between mental health and drug and alcohol services can somewhat suggest or impose a sequential or a parallel approach to managing and assisting people who are experiencing comorbidity. And certainly research, professional training and clinical care remains somewhat entrenched in this segregated view of addictions and mental illness as somewhat unrelated entities, despite most people living with both substance use and mental disorders at the same time. And certainly from a policy perspective and a systems perspective, we haven't really made many inroads into addressing this particular barrier. And that's why initiatives like ComDARN are so important, and why I'm particularly excited to be here today, because it's one of the few examples that we can see and identify and also evaluate, I guess, of groups and sectors coming together towards a common goal. We also see that clinical funding streams, professions and treatment infrastructure really does still remain segregated and set within the mental health or the drug and alcohol services in which clinicians and service providers are located. The services that we were able to identify who were trying their best to respond to this issue of comorbidity, which really does affect just about every clinician and service that we can think of and that we could identify, that these tended to be in-house models of care, and they weren't largely evaluated or weren't available for us to include in the review. So again, we see a bit of a gap here between what the researchers sit in their laboratories and the policymakers can put forward as ways in which comorbidity should be and needs to be addressed and managed in the real world, but a real gap between the ability of services to be able to respond and adopt those kinds of needs. And largely we really found that comorbidity was being dealt with on a case-by-case basis, with individual clinicians garnering their own model of comorbidity treatment rather than necessarily by an established model of care that was taken on by the whole service. And this is not to poo-poo or to bag the clinicians or the service providers that are working so very, very hard out there every day. It's also something that it was reflected nationally in Australia, and also that we see internationally. So despite some isolated examples of good practice, only around 7% of people generally receive treatment for both their mental health and their substance use problem. And this is despite evidence-based consensus that integrated dual diagnosis services are really the most effective and efficient standard of care. But the great majority of patients and people with these co-occurring disorders are still unable to access these integrated treatments. And so with that particular, I guess, situation or those particular things and challenges in mind, the question we then tried to consider as part of the review was how should we really treat comorbidity in Australia? And so certainly I wouldn't discourage anybody from carrying out a single focus treatment, and that is to manage a person in terms of help a person manage their mental health symptoms when they still have drug and alcohol symptoms or problems present, and vice versa, because the evidence also suggests that these single focus treatments are at least partly effective for people with comorbid concerns. So doing something, and certainly something that's evidence-based, even if it is a single focus treatment, is much, much better than doing nothing. But that certainly the research that we identified in the review and that CREMS has been producing over the last 5 years or so suggests that there are some additional benefits of integrating treatment that you don't tend to see with a single focus treatment, and that can certainly, I guess, help a person to take a bit more control of their own health care and manage their own symptoms and the interplay between the substance use and the mental health condition a bit more effectively. So to summarise some of those that emerging evidence, what we think we're seeing in integrated treatments where both a mental health and substance use condition is being addressed by the same clinician for the same person in the same treatment phase, it allows people to really explore and understand the links between the mental health symptoms and the drug and alcohol symptoms. Now that might sound like something that's pretty straightforward and a bit of the hors d'oeuvre in the room, but one of the most powerful things I think we can do for people who come to us for assistance or for guidance as to how to better manage their conditions and their experiences is to help them understand and help them tell their own story about how their symptoms developed and what their relationships are between symptoms, and then how that might affect their plans for the future or their recovery plans. And certainly we have been able to demonstrate, at least in the context of depression and alcohol use comorbidity as an example, that if you could offer an integrated treatment, people develop much better management skills for both disorders than if they get a single focus treatment. And an interesting thing that we've been able to demonstrate in our own research is that we can sometimes in an integrated treatment encourage a person to think about and make changes in areas that we aren't actually even targeting with this integrated treatment. So by way of example, in a research trial that we were carrying out at NDARC involving people with depression who also had an alcohol use disorder, our integrated treatment focused on depression and also alcohol use problems and the interplay between the two. And when we presented cognitive behaviour therapy or motivational strategies or mindfulness techniques, we made sure that we always talked about them in terms of how you would apply them to a symptom of depression, how you would apply them to a symptom of alcohol use disorder, and how they might have the same strategy might then generalise to one or both of those conditions and the relationship between them. And what we think we saw was that people were then able to, by demonstrating that how to generalise kind of message, how to generalise strategies, people were able to continue on with that generalisation process and take some of the CBT strategies we were teaching and working together with them on in the treatment they were receiving and apply it to things like post-traumatic stress symptoms and tobacco use. So what we saw in our DAISY study, the thesis reporting on this particular outcome is there on the slide in front of you, is that people reported significant reductions in post-traumatic stress symptoms at post-treatment for those who participated in our integrated treatment. And they didn't see, people who didn't receive that integrated treatment didn't actually make those same kind of improvements in terms of trauma symptoms as those did in the integrated treatment. And what we also saw was a clinically significant reduction, so not statistically significant, but clinically significant, reduction in tobacco use was also reported by people who'd been exposed or participated in this integrated treatment for depression and alcohol use. So we may be getting some unintended benefits of integrated treatment by offering this kind of I guess a comprehensive and an integrated method of addressing a person's mental health and substance use. And so arising from the review, we made some key recommendations for the New South Wales context. And I'll just talk about, I won't talk about them all now, but I'll talk about a couple from the service or the intake level and then some from the individual therapist level. So largely at the level of the service, there was evidence and we made a recommendation that there really should be this no wrong door approach, that wherever a person with comorbid mental health or substance use problems happened to present for treatment, that there really needed to be a response within that treatment service that helped them actually perhaps address some of their initial levels of distress before they then put them onto another service that may have been more appropriate to their needs. We felt strongly, and the evidence suggested, that screening really needed to occur at all entry points for both mental health and substance use problems, and that screening tools needed to be brief and easy to administer so that people without, say, high-level psychological or psychiatric training would also be able to administer them and also interpret their responses. So if we're looking for something that perhaps everybody can do, walk out and do right now if they're not doing it already, but they need that it's this screening for both mental health and substance use problems, no matter where a person comes across and asking for treatment. We also saw, particularly in the evidence-based clinical models that we're able to identify were currently in place, that this principle of assertive care, where appropriate, really helped to increase the retention in treatment of people experiencing mental health and substance use comorbidity. So by assertive care, we mean actively following up missed appointments, reaching out to people to try to engage them back into treatment, and in some cases where work health and safety and other sorts of considerations are all in place and where appropriate, to actually take treatment and assessment out to where a person is, maybe to outreach to a home or other safe environment, or a community health centre nearer to where the person is living. And that principle of assertive care really does make a difference regardless of the type of intervention that's being offered to a person. Also important is for services to identify and address problems that lead to treatment dropout, particularly at those transfer points between providers and between services and sectors. So if a person is going to drop out, then it tends to be at that transfer point, which is why this no wrong door approach and screening really does need to occur at every door, at every threshold at which a person seeks treatment. And ideally, it would be great if we could fund and support care coordinators to coordinate the provision of care for people with comorbid mental health and substance use problems. And this is to ensure their continuity of care right from screening through to discharge and referral, and also to manage effective communication between services and sectors, rather than making the client responsible for doing and negotiating this on their own. So even as a researcher and a person who's worked in and around clinical services for many years, it's quite a daunting thing for me to try to manage on my own, let alone someone who's also challenged by mental health symptoms and drug and alcohol problems. In terms of the actual treatment approach, we think is important, both based on the evidence and what we could glean from the models of care that various health services were already putting in place. It's really important to focus treatment on the impairment and the distress that the person is experiencing and reporting, rather than relying solely on trying to diagnose a primary or a secondary disorder. And certainly a clinically integrated evidence-based treatment approach that incorporates strategies, including assessment, for both substance use and mental health problems into the same intervention is really an important evidence-based and clinically indicated approach for the reasons I've discussed already. Certainly there is a need to align treatment, care and psychosocial support with the best available evidence and also the national international standards and guidelines. So there really is a bit of a gap between the guidelines and those standards and what people feel able to deliver or able to access on the ground in terms of mental health and substance use comorbidity treatment. Also important and in fact critical. So a lot of our research has revealed in comorbid communities that a thorough assessment of all the presenting conditions and a brief feedback session about that, all of those assessment results, is really critical in not only in encouraging treatment retention and adherence, but also encouraging change, even from such a simple strategy. And that also then a thorough assessment of these presenting conditions can really help the person and the client, the clinician, decide on what to manage in the first instance. And certainly the most severe symptoms really need to be addressed first, so it's crisis type issues. And certainly critical to all of this is the development of really good rapport with a person, to actively engage and to engender trust and a collaboration in the treatment environment. It's the key treatment techniques that we found arising from not only our own research but from the review itself. And certainly this is something that we also saw reflected in the National Report Card on Mental Health and Suicide Prevention that was published a couple of years ago now, with recommendation 11 particularly highlighting the importance of using an integrated, comprehensive response for people with co-occurring mental illness and substance misuse concerns. And so hopefully you're not kind of thinking that when I talk about integrated treatment that you're going to be offering something like Professor Gallagher here in the slide. And I hope to talk a little bit about how to practically implement those types of treatments in a moment. Again, arising from the review, and if this isn't clear enough on the screen in front of you, this is a graphic taken from the report itself, the SAPS review report. This is a possible pathway of care that we think is not only populated by the best evidence-based approaches that we could find, but hopefully might be of some practical and clinical use if it was actually taken up within an individual service or between services. So certainly that critical initial step of universal screening and assessment using validated measures for both mental health and substance use problems, no matter where a person presents. And if there's no problematic substance use that's detected during that phase, then treatment as usual can occur, potentially through the mental health service. But also it's an opportunity at that point to provide the person with some information, also some congratulations about not actually using alcohol or other drugs, and provide them with some information about why that is important in the context of their mental health problem. And why this is particularly critical is that we've done some epidemiological research just recently that's revealed that despite affective disorders and alcohol use disorders being present and emerging at around the same time in people, in our community sample that we surveyed, people sought treatment up to 8 years earlier for their affective disorder than they did for their alcohol use disorder, despite both disorders being there at the first point in time. So that's why this comprehensive screening and assessment is really important, regardless of whether you suspect these issues are going on. Should a person have a mild to moderate disorder in terms of their substance use in the context of, say, presenting to a mental health treatment service or a severe substance use disorder, then certainly integrated holistic care is really indicated for the reasons that I hopefully have outlined already. So this might be some detox for a person's substance use concern, maybe an inpatient hospitalisation if there are crisis issues related to suicide or other severe symptoms. But along with that, it's important to consider whether a brief intervention, e-health interventions, or some consultation facilitated referral is important to help this person best manage the particular spot that they are in at this point when they access treatment. And then, as always, the opportunity to monitor for improvement, monitor for change, or to provide feedback to all the people involved in a person's care is important, and can certainly then indicate where more or more directed treatment is required from that point on. The reality, though, for these models of care and these clinical treatment pathways that we're trying to work up and identify and then implement is that hurdles still exist in our policies and our systems. So again, the National Mental Health Commission's report card in 2011 still highlighted that workers are often not supported to work in this way, in an integrated, comprehensive way, because of siloed structures, inadequate funding, or constraints on professional development and supervision. So to some extent, it's all very well for us to produce a great report that looks all shiny and new and important, but if we can't actually use it to change practice or to help people access care and help service providers provide care that's evidence-based and helpful, more helpful for people with comorbidity, then what is it that we're trying to do? And this, I'll just spend a few minutes now talking very, very quickly about a potential innovation that we think and strongly feel will actually make a difference to the service provider on the ground and also to the person directly who is experiencing mental health and substance use comorbidity, and that is e-health. So by e-health, I mean, oops, hang on, got a little bit fast by clicking there. By e-health, we mean the use of technology to supplement, to augment and to optimise, if you like, treatment for people who are experiencing mental health or substance use or any other kind of health challenge, and particularly it might be useful for people experiencing comorbidity. And certainly the evolution of e-health means that sequential, parallel and integrated and stepped care approaches to comorbidity can actually likely be efficiently offered to people experiencing comorbidity within the one service setting, almost at any point in the treatment setting and engagement process, and potentially with little change to clinical practice. So this brings me to my second poll question, and that's to the group whether you've actually had exposure to e-health interventions in your work and how often you actually try to incorporate these e-health interventions in your work. So we've only got about 10 to 15% of our attendees today saying that they sometimes or frequently integrate e-health interventions into their clinical work. And that's really, really common, no matter when we go out, no matter where we go out and talk about these types of things. So 62% of our attendees today are saying they've never actually used e-health interventions in your work. And that's one of the concerns and things we're trying to focus on in CREMS, is that for all the potential of e-health, we're still needing to answer some pretty critical translational questions. And so the potential of e-health to respond and to better support services and also individuals to access care for evidence-based care for comorbidity is based on this widespread recognition and growing recognition within the health sector that better use of e-health initiatives can really play a critical role in improving healthcare system, but also this increasing acceptance and importance for people experiencing mental health and substance use comorbidity and also health problems more generally to take a much more active role in protecting their health and participating in their own healthcare as active participants rather than just recipients of treatment. And certainly the best outcomes that we've been able to identify and achieve in our own research have developed from these collaborative partnerships. To the extent where in the SACS review, we actually made a recommendation that at a treatment level, treatments should use evaluated e-health technologies to support treatment where appropriate, including using technologies for early intervention. And this is also facilitated by our increasing access to technology. So I'm sure it's not a surprise to know that internet access and smartphone ownership is rapidly increasing. We've got 87% of Australians have access to the internet, 64% own a smartphone, and the highest rates of smartphone usage are among our young people. There are now more mobile phones than there are people in the world. And this has really been a catalyst for this exponential growth in mobile applications and apps and e-health technologies. But what about people who are experiencing mental disorders or people who are experiencing alcohol and other drug use disorders? Is there a digital divide between people who have access to the technology and people who could actually benefit quite a lot from accessing this technology? So are we actually creating yet another barrier for people in accessing treatment by moving to an e-health type model of intervention? So we actually decided to ask people coming into some of our studies at NDARC and also at the University of Newcastle, with whom I also have an affiliation, whether they actually had access to the internet, a smartphone, whether they would use these kinds of approaches to help supplement or augment their care, and what their general feeling was about having to interact with a phone or a computer to get treatment for some pretty serious issues like PTSD, like depression and comorbid alcohol and other drug use. And surprisingly for me, I guess, we found, this is a couple of years old now, this data, that access to technology, even amongst people with quite severe mental disorders and quite severe drug and alcohol use disorders, actually were reporting roughly similar rates of access to the internet as the general population. So really there doesn't seem to be as much of a digital divide as we thought. And so considering on average that 87% of the Australian population report internet usage, we can see sort of up around 80% of people in our study across all of our different groups were reporting access to the internet. And I can only expect that this has grown since then. And so that's all very well then that we've identified maybe that there's one less barrier to implementing e-health in this context, but are people actually interested in using e-health interventions as a part of their healthcare experience? So this comes to our final poll question today, and that's whether you think, and if you think about your clients or the people that you've had experience with, whether you think they'd be interested in using e-health interventions. So we're getting about 50% of the group saying that they think their clients would be moderately interested, about 10% very interested, and about 40% mildly interested. So thank you so much for filling out those polls, and that really does reflect what we saw, what the people in our studies were telling us, and that is that for a lot of, about half the people, people had also previously used the internet to seek information and treatment for mental health problems, somewhat less so for drug and alcohol problems, but that's probably because of a lack of availability of online treatment programs for drug and alcohol. And that interestingly, people with more severe symptoms actually reported more use of the internet for mental health and substance use problems than people who had mild to moderate symptoms. And certainly, by and large, people who answered our surveys would really consider using the internet to help access mental health treatment and drug and alcohol treatment. So certainly in these small surveys that we conducted, we were pretty happy to learn that there was a great potential for the internet and mobile-based interventions in assisting people to access and benefit from e-health treatment for psychological disorders. So there's a high access to technology in this population and a high interest for these types of interventions. And so certainly in thinking about what we can walk away and do for people who are coming to us for assistance with managing mental health and substance use comorbidity, e-health is certainly worth a try and worth considering incorporating into our clinical practice and our service provision. The evidence, I don't have time to talk about it all today, but I'm very happy to do so on another occasion, are that treatments are as effective as face-to-face interventions, particularly when they're supported by very brief check-in sessions from a clinician or a trusted coach, if you like, and that for programs like the SHADE program, we are able to apply these e-health treatments very effectively to complex presentations and complex cases like comorbidity. The people themselves find it as acceptable as face-to-face treatment, which I found really remarkable and quite encouraging. People have ready access to the internet, but also clinicians themselves can use these types of approaches to save time whilst offering more comprehensive and specialised treatments, and that more crisis and immediate response to impairment and distress that we've identified in our review is so critical in this particular population. And so regardless of whether it's a model of comorbidity or an e-health intervention, the vital piece in the puzzle of how to effectively address and provide care for people experiencing mental health and substance use problems is really the clinician. And certainly we still see e-health or internet treatment as a useful step within a larger therapeutic process, but that does have a lot of potential and a lot of opportunities to explore. So much so that New South Wales Health have recently funded CREMS to develop an Eclipse online portal for mental health and drug and alcohol services that actually helps broker access to these evidence-based e-health programs, some of which I've mentioned very, very briefly today. So we're developing over the next 2.5 years, we've got about a year or so left to go, an online portal that incorporates and builds a clinical pathway to care that builds in these access to e-health programs at various critical points in the clinical care pathway for people with mental health and substance use problems. And we're working with 2 local health districts to actually build this portal appropriate to those local LHDs, and then to trial and evaluate how useful that portal is, and then providing those e-health programs are to clients in those particular services. And we'll be working with mental health and drug and alcohol services in each of these areas. So New South Wales Health is looking to invest in these kind of models, which is really exciting and very innovative and cutting edge. And stay tuned. I hope to be talking with you all a bit more about that soon. So thank you so much for your attention so far. I look forward to answering some of the questions that people have been sending through. And for information about any of these things that I've mentioned today, please come to our website, of course, comorbidity.edu.au. Thank you.
Hi everyone, this is Angela back again. Please stick around. We've got a few things left to get through. We welcome your questions, so please start feeding them through to us. First of all, lots of the questions that we've been hearing so far about, will the materials that you've been watching today be available? Yes, within 2 days there'll be a copy of the slides and a link to the webinar available, so you're very welcome to access those as soon as they become available. We also have a bunch of questions that I put up at the beginning today that I'd like to return to ask Frances while you're getting your questions to us online as well. So the first question I have for Frances today is how do we go about translating this important research into better practices?
I think that's a really, really good question, and certainly that's where the gap is and that's where the opportunity is. So I think it's all very well for researchers to sit in our offices or our ivory towers and try to think about great models of care and e-health programs and so forth that might help people out there in the real world. But we actually need to be partnering right from the word go with real people in the real world, be they service providers or the people experiencing these conditions themselves. And so I think it starts with these types of conversations that we're now having with the Eclipse online portal, actually going out and saying, this is what the evidence suggests, this is what we've been able to develop and recommend based on all of our expertise as either an expert in your own healthcare, a person directly experiencing these challenges, or the service providers dealing with these problems every day. What does your expertise say about how we can actually close this gap itself? So there are some really exciting opportunities available, and certainly potentially you can access that through the research network by some of those mentoring research questions. But we actually need more researchers to partner with clinicians and clinicians to partner with researchers to answer these critical questions. And as a question will come up a bit further down the list, and making sure that in that partnership we include the consumers themselves.
Thanks, Frances. And what advice would you give to service providers in considering implementing a new model of care? If service providers could implement something small that would make a big difference,
so for me it's screening, it's assessment. So making sure that the people are assessing both mental health and alcohol or other drug use, regardless of the service context in which they are working, and regardless of whether they actually think the person is using, for example, alcohol or other drugs. Sometimes those things can fly under the radar. And so so assessment as a first step, and then perhaps for example, if you're in a mental health service, identifying some e-health interventions that might be able to supplement, say, a mental health intervention that you're able to deliver, or that you're trained and feel comfortable to deliver. There are some great websites websites around. You can access them through our Comorbidity website that actually help people directly themselves to manage drug and alcohol use problems. There are some drug and alcohol prevention websites, there are mental health prevention websites, and mood management and those sorts of e-health interventions right now that you can walk out the door and access and encourage the person that you're treating to access if they're open to that kind of idea. So assessment and then perhaps some e-health tools. I think this is a tough one because it certainly is it's tough. So I think at a very base level, it'd be great if people could feel comfortable asking about mental health symptoms and asking about how you start those conversations about drug and alcohol use, for example. So I know in one of our trials, I was working with a clinical psychologist who'd been working for years in mental health, and she came along and she goes, well, how do I talk to someone about their drinking? So understanding and getting some training in things like motivational interviewing can really give a person a language, a service provider a language about how to ask and talk about these types of things, and they're really not so scary to ask about as well. I just noticed on one of the questions that just came up, someone was asking about the DDCAT, which is a dual diagnosis capability assessment tool, which I really like. But it enables a particular service to actually, you can access this online, and we're currently working with New South Wales Health to see whether it's something that we could trial and work with within some of the service contexts here. It actually helps a particular service and the clinicians within a service work through their policies and practices and training needs and comfort levels and requirements in order to become dual diagnosis capable, if you like. So I think that's also a great starting point for understanding what the training needs are and what the comfort levels are of people offering this kind of integrated treatment package. But I guess a general rule of thumb is, for me, if I'm talking to a person about a mental health symptom, I'll make sure that I'm also going to provide an example or ask them or talk about a drug and alcohol symptom if both things are present.
Which theories then regarding the development of drug and alcohol dependencies best underpin treatment for comorbidity?
I think that's a really tricky one because the theories that we have at the moment about how and why comorbidity develops really have driven the service organisation and responses, or traditional service organisation and responses to comorbidity. So trying to establish a primary disorder and a secondary disorder. So does the person have a primary substance use disorder or a secondary substance use disorder? Really then sets the scene for the type of access for treatment that they might have. So if it's considered that it's a primary substance use disorder, a person tends to get drug and alcohol treatment and vice versa. For me, I think with the models that are available for comorbidity, which in addition to the primary or secondary, look at whether both things are interrelated and affect each other, or also whether there's a common external factor that influences both the development of a mental health disorder and a substance use disorder, so something like genetics. All of those models can be clinically quite helpful and can give a person a bit of a context for understanding how and why their symptoms have developed, but there really isn't a strong evidence base for one theory over another. And that's why we've come back to this idea of trying to focus on the distress and the impairment that a person is experiencing when they present to you for treatment. And that kind of opens up the way for this no wrong door approach. So you can address and help a person manage that impairment and distress regardless of potentially what the stimulus is.
How do we then best meet the needs of individuals with longer-term co-occurring issues? For example, say a person successfully completed AOD treatment while maintaining sobriety in the past, but is now faced with escalating mental health issues.
And I think, that's it's a good question and also a complex one. And I think what we will see is that as we work with people and are able to work with them over the longer term, that the relationship between the drug and alcohol use and their mental health symptoms will actually change over time. So sometimes the drug and alcohol will be more distressing and more impairing, and other times it'll be the mental health problems. But then they can act to exacerbate each other. So in that example, I think it would be important to offer an integrated package, of course, that helps a person understand how that, or what how drug and alcohol use has been affecting or self-medicating, if you like, the mental health symptoms, if that happens to be relevant, and then encourage them to keep going with their sobriety and develop some strategies, say via cognitive behaviour therapy, that a person can apply to both their substance use and their mental health symptoms as it goes on.
There are often co-occurring acquired brain injury cognitive impairments with alcohol and other drug use disorders. These are often not considered or diagnosed as mental health related. How do we support consumers experiencing this issue?
This is a really critical issue, I think, and we've done a little bit of research on cognitive impairments in some of our comorbidity studies that we've recruited recently. So Sally Hunt, H-U-N-T, has published those results. If people want to contact me, I can certainly supply the papers. So we did some cognitive assessments, assess for cognitive impairment in people coming in with really long-term alcohol use disorders and severe depression. And what was interesting is that we were able to detect some deficits in attention and concentration and working memory, so their ability to take on and maintain a focus and a memory of a concept. And that for those people, it was really important to that it then had a flow-on effect to their motivation and their willingness and their ability to change. And so I guess the clinical message from that particular research was that for people who we think have some kind of cognitive impairment coming into treatment, to work with them a bit more on motivation and build and goal setting in those earlier stages of engagement, and also to provide some pretty clear, concrete, written down type examples of things. What was interesting though is that levels of cognitive impairment didn't actually affect a person's ability to make use of an integrated treatment message. We thought that perhaps if a person was experiencing cognitive impairment, that they might not be able to really get the benefit out of a multiple message and interrelated kind of treatment that integration offers. But that actually wasn't the case, provided a bit of groundwork had been done in that motivation, building motivation to change type phase.
Another one of the questions we've been asked, Frances, is although consumer consultation is mentioned in the review, the models of care seem to be based on expert models. What's the place of the consumer as expert in their own care? How do we bring this to service delivery? And how do we evidence the efficacy of this approach?
I really think this is critical. And we see it across all of the research and all of the clinical work that at least I've been involved in that we can develop amazing gold standard expert-driven treatment programs that people themselves have trouble engaging with or don't like engaging with for a number of reasons. And if a person doesn't engage with the treatment, then it's really hard for them to get any sort of benefit from it. So having strong partnerships with consumers who are quite capable of being very active agents in their own healthcare, listening to what they want and need, is really critical. And building those kinds of formal consultations in right from the word go, that we're thinking about whether it's whether it's an assessment or formulating a treatment plan with a person, or in a research context of actually engaging with the end user of our treatment services right before we even develop the programs themselves, I think really makes for a really good and much more effective model than some of the models that we've seen so far. It's been really interesting with this Eclipse online portal development going out into these communities, and we've actually had focus groups where consumers and clinicians have sat side by side, and we've spoken a little bit about e-health. And the clinicians in their own focus group previous to the one with consumers have said, I don't think my clients would really go for e-health. They wouldn't have access to the internet. They wouldn't really go for this type of thing. And so then when the consumers have come in, they've gone, this is great. I'd love to have a go. And so they've really, and to watch the clinicians and also we as the researchers see that shift based on what the client is actually prepared to give and have a go at has been really quite powerful and so important. So I think those partnerships are critical.
What kinds of translational research?
So I think we begin by having conversations like we're having today, by linking researchers and clinicians together through, like this research network, and encouraging, instead of, say, for example, the researchers driving the research questions and the treatment questions that we see are the gaps in the literature, actually having that come the other way, whether it's driven by the consumers themselves or driven by the clinicians themselves, to really help better understand a particular challenge they might be experiencing, or to test out some assumptions they might have made in a pattern or a group of clients who've come across their doorstep. And so I've noticed that at the moment we've got these New South Wales Health Translational Research grants on offer, and so I think those kinds of schemes are really critical and really important, and for mine really exciting, that clinicians need leading these kinds of research grants that have outcomes that are relevant to the consumers and the service providers, and that do require a bit of research expertise and advice, but are really being driven back from the clinicians and consumers themselves. I think that's a great start.
One of the questions that's just come through to us, Frances, is did you and your team look into the dual diagnosis capability and addiction treatment index to assist with EOD services?
So that's really interesting. So that was the DDCAT that I just briefly mentioned before, and certainly it did come up as a really, really useful tool. So there's it's a capability assessment tool that assesses across 5 different domains and needs of a particular service, right from the policies through to the staff training, the culture and the climate, the assessment and the treatment approaches. And there's one tool that's for mental health services and one tool that's for drug and alcohol services. And certainly these kinds of capability assessments that really haven't taken off much here in Australia yet, generally speaking, from the review that we did, but tend to be used quite a lot in the US, I think can really help structure some of these conversations that, and future research that we've been talking about already today. I'm not aware of any other formal capability assessments for dual diagnoses, or for the integration of drug and alcohol into mental health services, for example. But certainly that DDCAT, DDCAT, if you Google that, you'll be able to locate the tool, locate the assessment, or give me an email, and I'm happy to work with services who might want to work through that kind of an assessment tool as well.
And Frances, what was the statistic for comorbid disorders versus single disorders that you mentioned earlier?
Okay, so that's the prevalence, perhaps. Okay, so what we find is that about 1 in 4 people with one mental disorder will meet strict the diagnostic criteria for another mental disorder, including a substance use disorder. When you relax that strict diagnosis threshold, what you find is that up to 50% of people with a mental health disorder will have a problematic substance use disorder, and it can be as high as 80% when you think about people with substance use disorders also experiencing mental health symptoms or mild to moderate mental health symptoms. So it's quite frequent.
What's the most common presenting issue for people with severe mental illness who've been shown to be, and what's been shown to be effective in treating them at a service provision level?
Okay, that's a tough one. The most common presenting issue for people with severe mental illness in terms of drug and alcohol, I think, is that what the person's asking? That so often it's still the same as it is in the general population. You still see extremely high rates of alcohol use, particularly in people with psychosis and people with depression and anxiety. Next common will be cannabis use problems, although that's slowly being caught up to by methamphetamine, which we are seeing a fair bit of at the moment in mental health populations. And by and large, tobacco use even overrides alcohol and cannabis and methamphetamine use as one of the most highly comorbid substances a person with severe mental illness will use. And there was a second part of that question, I think. What strategies can we use? So certainly again, this integration. So I'm a psychologist by trade and by background, so I'm an advocate for psychological treatment approaches and psychosocial treatment approaches that encourage a person to think about and try to understand links between their disorders. So motivational interviewing strategies, cognitive behaviour therapy, and particularly mindfulness-based stress reduction techniques are really, really effective in all of the contexts that I've spoken about today. Certainly they're not the be-all and end-all, and you do see real benefits for integrated treatment, including medication as well as psychological and psychosocial treatments, and certainly also you can do that for both the mental health and also the substance use concern.
We've had a question too about the war on drugs and how the war on drugs, which kind of creates and inflates the problem of existential choice for some people. What sort of major approaches do you think that this, and what influence has this exerted on increasing the focus on brief therapies in stages of change? And is there a major increase in mandated and resistant clients in AOD services around this?
It's interesting. So the short answer is I don't know. I'm just having a bit more of a read through that question, if that's okay. So certainly in terms of this war on drugs, and every year or a couple of years there will be a new trend or a new drug of of concern for people, and I think we do need to be very careful of as a society of labelling disorders and problems and epidemics as such for a number of reasons. Number one, it can make people feel quite helpless and powerless and quite stigmatised in seeking treatment or thinking that they need to seek treatment for their problem. And secondly, also, it can somewhat normalise behaviours. So we're doing some work for the Commonwealth at the moment on an online ICE toolkit. And one of the things we want to try to communicate to people is that even though we're seeing a lot of this war on drugs, particularly around methamphetamine, the prevalence of methamphetamine use is still around 2% of the population, which is significant, but that generally hasn't increased a lot over the last 10 years or so. More people who are using methamphetamine are using ice, and the harms associated with ice are much, much worse than, say, for other types of methamphetamine. So certainly then focusing treatment and the things that we are saying in the media and offering in our services on the harms around drug and alcohol use, I think is a really important way to go. And I think that's much more appealing to a person who might be considering mental health and substance use treatment particularly. I'm not sure that answered all of the question, but okay.
It was a start. Thank you. And what are some of the current examples of emerging integrated service delivery?
So we couldn't identify at the helicopter level that we were looking at, and in the brief time available, of these truly integrated treatments that I've mentioned, where the one person is delivering both a mental health and substance use integrated treatment, and certainly our ability to translate our evidence-based integrated treatments has been pretty bad, which is why we need to really partner with clinicians and services to talk about how best to try to do this. Certainly we saw some examples, and the MSUS unit in H&E Health, LHD, was one that comes to mind, where they've tried to integrate a drug and alcohol service within a mental health service for people who come through the inpatient ward or who need to re-engage by mental health services with some drug and alcohol interventions. And that's based on an integrated care model, I think, that was developed in the States, and ISHMU, I think it is. Integrated substance abuse and mental health treatment, and that's really involved a whole service reorganisation and reorientation, and that's been working really well, I think, for 10 to 15 even more years now. But other than that, we saw isolated examples of coordinated care providers being funded to take on patients with comorbidity and try to be a broker, if you like, between all the systems of care for a person. We also saw some examples of alcohol and drug clinicians swapping places with a mental health clinician counterpart and doing some month or 6 week placements in each other's services, and then bringing that knowledge back back to their own service when they return to their position, as a way to try to encourage that kind of an integrated focus. But generally what tended to happen was that that person then became the comorbidity person in that service and tended to get those clients. So again, it wasn't necessarily a service approach to integration, at least that we could identify in the short term available. So I would really encourage the people out there, if you do have examples of this kind of practice that we haven't captured in the review, to please publish it, to at least, I don't know, pop it on a website or do some media around that model of care so that we can capture what you're doing and then follow up on it, or maybe partner with one of the researchers in the network to do a little evaluation around that model of care. It's really needed. Yeah,
absolutely. Collaboration and publication is really what we need at the moment. One of our other questions was about just the resources available around e-health. There are so many.
So my preferences are for evidence-based treatments, of course. I have some biases towards the ones that I've been involved in developing. So there's the SHADE, S-H-A-D-E treatment program, which is for comorbid depression and alcohol and cannabis use. There's also the DEAL, D-E-A-L program, which is for younger people with depression and binge drinking problems. I think if people go to the comorbidity.edu.au website, we'll be able to link you in with some of those evidence-based e-health interventions that we've been involved in developing, particularly for comorbidity. But also there are other programs out there like Mood Gym, which is for depression, and eCouch through the Australian National University, and St Vincent's Hospital also through CRUFAD, C-R-U-F-A-D, offer some brilliant automated online treatment programs for anxiety, for trauma and for related issues. So no wrong door is a very, very simple concept, and that is not to turn a person away because they don't, say from your mental health service, because they have a substance use problem there as well. People can benefit still from a mental health intervention even if they are still current and active in their substance use, and vice versa. So no matter where a person presents for treatment, particularly for comorbid people who just have trouble finding a good fit and can get very, very dispirited and drop out of treatment very frequently, a no wrong door means please offer them something, even if they don't exactly fit in the service, I guess, philosophy or criteria.
Wow, well, thank you, Frances, for all of the fantastic ideas and information and unpacking that you've done for us today. That's really brilliant. We hope that all of you have found today's webinar useful and will be able to translate some of what you've heard today into better approaches and practices. Frances and I have been sitting here as kind of gangsters or DJs with our little microphones on. We hope that you've enjoyed everything that you've heard. Thanks to everyone for participating. We'll be in touch within 2 days with a copy of the slides and a link to the webinar. So you're welcome to rewatch it at your leisure.
Thanks, everyone.